Hi, my name is Megan, and today I'll be presenting on my project from my internship this summer with the Oxford University Clinical Research Unit funded by the Center for Health and Wellbeing under the Health Grand Challenges program. My project was on the patterns and determinants of antibiotic prescribing in primary healthcare in Vietnam. This has to do with antibiotic resistance, or AMR, which is one of the most urgent public health crises in the world and is especially bad in low and middle income countries, which are more likely to lack the health resources for proper antibiotic stewardship. Vietnam in particular has one of the highest AMR rates in the world. So this study is meant to learn more about the antibiotic prescribing trends in the country to inform the development of appropriate interventions in antibiotic stewardship. The first thing that I did in this internship was conduct background research about the topic. So to do this, I would read journal articles and related existing studies on the factors affecting antibiotic resistance and prescribing. In addition, I also read reports from health research groups like the World Health Organization to see what general trends there are worldwide. The next thing I did was to use data from surveys given to prescribers throughout Vietnam and to visualize and conduct statistical analyses on this data to see the trends and correlations in responses from prescribers. In total, there were 305 respondents of all different qualifications. However, only 210 of them were actual prescribers, such as doctors or assistant doctors, and only these were included in the final analysis. In the results, we separated our findings into three sections of knowledge, attitudes, and practices. Under knowledge, we found, using the survey responses, that prescribers showed insufficient knowledge of antibiotic drugs and of antibiotic resistance. In addition, their training is also insufficient because the most common AMR form of training is from medical school, despite most prescribers being in their 40s or 50s and having attended medical school decades ago. Only 41% have had specific recent training from the Ministry of Health, which shows that there is a severe lack of outreach in terms of who is actually getting up-to-date data on AMR rates. In addition, the vast majority of prescribers, or 97%, seek better clinical practice guidelines. And some prescribers also believe that the current existing guidelines either were not enforced at all or were not actually sufficient for their needs. Next were attitudes, where doctors reported that they don't seem to think they see many patients with resistant infections often. They also have varying perceptions of how the prescribing even affects local AMR patterns, which has been seen in existing studies. As you can see in the figure, most doctors believe that their prescribing only mildly affects local AMR. However, this is also spread from very weakly to very strongly. On average, doctors also have a high rate of self-efficacy when antibiotic prescribing. Self-efficacy is the confidence that you have in yourself in order to prescribe the correct antibiotics at the necessary time. This is interesting because past research has not really looked into self-efficacy rates in low and middle income countries where there are a lot more complications with diagnostics and resources and antibiotic availability. For the practices, it is found that the doctors prescribe antibiotics frequently each week and for most patients with acute respiratory infections. However, most of these ARI patients do not require antibiotics, which is one of the reasons why antibiotic prescribing is so rampantly unnecessary and why AMR is so high in Vietnam. The two most often cited reasons for prescribing without this indication of a bacterial infection is clinical uncertainty and the lack of diagnostics, which are both seen in other LMICs that have the similar factors in antibiotic prescribing. In addition, there is a severe lack of communication between doctors and patients on the topic of antibiotic resistance, which also shows in the sort of cultural implications surrounding antibiotic use, where many people seem to think that it's a form of miracle drug, which it is not. Also, 93% of the prescribers reported that they had experienced shortages of antibiotics, which is another factor that's common in LMIC prescribing. Overall, these prescribing practices seem to reflect what doctors have seen in other existing studies. Overall, it is found that the doctors in Vietnam show a lack of understanding about AMR and a shortage of training, and that clinical uncertainty, the lack of diagnostics encourage this sort of empiric antibiotic treatment, and that communication and AMR between doctors and patients need to be heavily improved. As a thank you for this project, I would like to thank the Oxford University Clinical Research Unit, along with Dr. Sonia Luca, who was my mentor for this project. And of course, thank you to the Center for Health and Wellbeing and Health Grand Challenges program for their support. Thank you very much.